Welcome, everyone. Thank you for joining our UC System-wide Grand Rounds. Our topic today is drug shortages, the persistent consequences of a vulnerable drug supply chain. I'm Deena McRae, the Associate Vice President for Academic Health Sciences at the University of California Office of the President. We're happy to host a series of presentations to help our UC health community and colleagues remain up to date on hot topics and issues that impact our profession and the communities which we serve. This Grand Round series also serves as an opportunity to showcase some of the extraordinary innovative work that's occurring across our UC health system, work that is inspiring others across the nation and around the world. I want to thank everyone who helped create and support the UC System-wide Grand Rounds, Lisa Badavinas, Amanda Berry, and Benjamin Wallen. This is a CME event. You will receive an automated email tomorrow with an opportunity to receive credit. Time will be allotted for answering questions at the end. Please feel free to use the webinar Q&A feature for entering questions throughout the session, and we'll answer as many questions as possible at the end of the presentations. The speakers do not have any disclosures. I'm honored to be here today to showcase 3 expert leaders from our UC Schools of Pharmacy at UC San Diego, UCSF, and UC Irvine. They'll be discussing the reality of drug shortages and what UC is doing in response to the shortages, as well as share some tangible case studies. We will first hear from Dr. Inma Hernandez, who's a professor at the University of California, San Diego Skaggs School of Pharmacy and Pharmaceutical Sciences. Dr. Hernandez is a pharmacist and a scholar whose research focuses on improving medication use, outcomes, and equity in access. She has made major contributions to improving transparency in the drug reimbursement system. Dr. Hernandez has authored over 100 scientific articles and currently serves as the National Academy of Medicine Fellow in Pharmacy. Dr. Hernandez is a pharmacist by training, and she earned her PhD in Health Services Research and Policy from the University of Pittsburgh. She was recognized on the Forbes 30 Under 30 list in 2018, and in 2021, she became the first pharmacist to be recognized with the Academy Health Alice S. Hirsch Emerging Leader Award. She will be followed by Dr. Melanie Joe, who is the Chief Pharmacy Officer at UC Irvine Health and the Associate Director and Founding Associate Dean for Pharmacy Professional Affairs at the UC Irvine School of Pharmacy and Pharmaceutical Sciences. Dr. Joe has over 20 years of pharmacy leadership experience in numerous positions, such as Residency Program Director, Clinical Supervisor, and Director of Pharmacy. She currently is the Chief Pharmacy Officer at UCI Health, where she has oversight of the regulatory and compliance, financial, operations, and strategic business development for the pharmacy enterprise, which includes a level 1 trauma acute care hospital, 4 retail pharmacies, and 5 ambulatory infusion centers. Dr. Joe provided leadership for the creation of the UC Irvine School of Pharmacy and Pharmaceutical Sciences, which opened in 2021. And she's the Associate Director and Founding Associate Dean for Pharmacy Professional Affairs. In her tenure at UCI Health, the PGY1 residency program grew from 2 to 10 positions, and 3 new PGY2 specialized residency programs were created. And last, we will hear from Dr. Catherine Yang, who is a health sciences professor of clinical pharmacy in the UCSF School of Pharmacy. She has over 25 years of experience as an infectious disease pharmacist specializing in the treatment of multi-drug resistant gram-negative infections. More recently, Dr. Yang was extensively involved in the institutional response to COVID-19 and monkeypox and serves as the pharmacy consultant to the California STI HIV Prevention Training Center. Dr. Yang teaches in multiple areas in the pharmacy curriculum, including foundational sciences and infectious diseases. She earned her doctorate in pharmacy from UCSF. After completion of her pharmacy practice and infectious diseases residency training at UCSF, Dr. Yang obtained her master's in public health from UC Berkeley. We are honored to have these prestigious leaders with us today. I now turn to our colleague, Dr. Hernandez.
Thank you, Dr. McRae, for the invitation to present today. It is an honor. I'm going to start talking a little bit about drug shortages, and I thought I would start with the definition. So in the United States, the Food, Drug, and Cosmetic Act defines a drug shortage as a period of time when the demand for the drug exceeds the supply of the drug. Shortages are concerning because they can lead to treatment delays, omission of life-saving therapies, or substitution with less effective and more costly treatments. For this reason, drug shortages contribute to adverse health outcomes and increased costs. In 2023, the United States saw a record high number of drug shortages with over 300 drugs on shortage. Drug shortages disproportionately affect low-cost generic products, most notably injectable drugs. There are many underlying factors contributing to shortages, but the primary drivers are economic and regulatory. My remarks today are going to center on the economic drivers behind drug shortages. So, as you probably know, generic drugs are the equivalent versions of the same product manufactured by different companies. Generally, the pharmacy or the provider or the health system can choose any manufacturer's version. It's important to note that the reimbursement that the insurance company pays the pharmacy or the provider is the same regardless of the generic version selected. As a result, obviously, pharmacies, providers, and health systems are incentivized to purchase generic versions that have the lowest cost. In other words, there's no incentives for pharmacies and providers to purchase drugs that come from manufacturers that have invested in resilient supply chains. These reimbursement practices have been important to keep the costs of generic drugs down. However, in some cases, they have led to price decreases that are so strong that threaten profitability. This is particularly the case because this pressure that has been created on the reimbursement side interacts with the consolidation of entities in the purchasing side. So nowadays, health systems mostly purchase drugs through buying consortia. We call them group purchasing organizations or GPOs. So back in the day, a health system could directly contract the purchase of drugs with manufacturers. But now, again, they do this through these third-party entities. And the idea is that by aggregating volume, these buying consortia are able to achieve better rates than individual health systems could on their own. It is estimated that 3 group purchasing organizations control the majority of the market. For this reason, they are able to pressure manufacturers into their own contracting terms and drive prices down. So the issue really is that the combination of these factors from the reimbursement side and the purchasing side has resulted in strong price decreases that in some cases threaten sustainability. What I mean by that is that in some cases, the prices of drugs are so low that manufacturers don't have incentives to produce them. This tends to be particularly the case of injectable generics. They are expensive to manufacture because of the requirements for sterility, and many of them have very low prices after decades of competition in the market. Manufacturers tend to respond to this decreased profitability by engaging in cost containment strategies. These include reduced factory maintenance, for instance, but also offshoring. Most generic drugs used in the United States are produced overseas, primarily in India and China. Cost containment strategies, including offshoring, increase the risk of quality issues. Indeed, it is well known that manufacturers in India and China receive the most FDA warnings for violations of good manufacturing practices. Quality issues generate shortages because production of the drug must be halted until the quality issues are resolved. In light of all of these challenges, in some cases, manufacturers may simply decide to stop producing the drug because it is not profitable enough. This further contributes to market concentration. What I mean by that is that very few manufacturers produce a certain drug, and that also limits the ability of the market to respond to supply disruptions. Meaning when one manufacturer shuts down a facility, there's not enough other manufacturers to be able to compensate for that. In summary, In the United States, drug shortages disproportionately affect older but affordable and essential generic drugs. This is the product of, first, a vulnerable drug supply chain that heavily relies on foreign manufacturing. Second, a reimbursement system that fails to reward manufacturers to invest in dependable supply chains. And third, the consolidation of entities in the drug supply chain. Thank you for your attention. I will now welcome my colleague, Dr. Melanie.
Thank you very much, Dr. Hernandez. As Dr. McRae mentioned, I'm Dr. Melanie Joe, trying to start my video here. And I'm from the UC Irvine School of Pharmacy and Pharmaceutical Sciences. I'll start my presentation by describing local strategies for drug shortage management. A paper published by colleagues at Yale New Haven Health succinctly described a lot of the local strategies that are commonly deployed by health systems to address drug shortages. Starting by looking at identification of a drug shortage. When a shortage or pending shortage is identified or recognized, which is usually by a procurement specialist in the pharmacy, pharmacy leaders are notified with the first response to identify the quantities on hand versus the historical use of the drug. This really helps to identify the urgency of the situation. There's consideration for how critical the identified drug is to patient care or continuation of services. Questions oftentimes pondered include, is this drug a drug that has many therapeutic alternatives? Or is this something that is used frequently for emergent medical cases? Next, further information is sought from manufacturers, wholesalers, and the healthcare community in terms of anticipated duration, allocations, and supply options. Next, the pharmacy team will evaluate drug alternatives, considering medication safety, availability of alternative therapies, equivalency, and changes to process or practice. Focus is on whether the use of the agent should be placed on restriction or if there are approaches to minimize drug use or waste. After a plan is created, the team will evaluate, after a plan is created, all stakeholders must be engaged. Communication with physicians, nurses, pharmacists, and other impacted services should happen early and often. Strategies to address shortages should be further brainstormed, identifying and minimizing any potential challenges. Next, new processes are implemented. Often, technology, including our electronic health record, is used to direct use of alternative therapies. Education and training of new processes or the use of alternate agents is performed. Finally, the shortage situation should be regularly monitored with frequent status reports to stakeholders. New strategies may be created and implemented depending upon the duration of the shortage. When supplies return, it's also very important to communicate this and to develop a new strategy to return to baseline processes or perhaps implement new approaches to drug utilization. At the system level, strategies often involve redistribution of inventory. Large health systems often have a central warehouse where excess inventory is stored. Centralizing inventory so that it may be deployed to locations with critically low supplies and greatest need is often performed. Recently, national community groups have been created, such as the End Drug Shortages Alliance, which was created to discuss and create mitigation strategies that were nationwide, and to develop some larger initiatives to address this problem. These groups are comprised of many stakeholders, including providers and representatives from industry, group purchasing organizations, manufacturers, and drug distributors. Civica RX, which is a nonprofit 501c3 organization, was created by hospitals to manufacture low-cost generics. This group focuses on manufacturing drugs based on greatest need rather than potential for revenue generation. Finally, there are strategies created by wholesalers to provide stability in the market, such as fair share programs, where allocation of drug is based on historical purchases. Or another example would be Cencora's Sure Supply program, where hospitals can select certain critical drugs and guarantee the wholesaler that they will purchase specified quantities while the wholesaler guarantees product availability. Pharmacy buyers often leverage knowledge of the wholesaler ordering systems in order to increase procurement opportunities. The UC pharmacy team, or excuse me, the UC System Pharmacy team has created the UC Collaborative Purchasing Group, which meets regularly to share ideas and status of drug shortage impact on each medical campus. The UC system also has been able to leverage its size to drive contracts with expected or established expectations, including par and service levels. Also, the UC system has arranged with its wholesaler, Cencora, to have weekly meetings with each medical center's pharmacy leaders to address supply issues. If needed, Cencora will triage drug supplies to the appropriate local warehouse, which improves the supply of drugs from which the health system can place an order. As part of our system-wide collaborations, we've established the pharmacy collaborative teams called PCTs. All of the PCTs and work groups meet on a regular basis and report out projects to the pharmacy chiefs at each of the five medical centers, as you can see on the map here. These groups have at least one member from each of the 5 academic medical centers, and the leadership rotates. We've developed a charter for the structure and format for project development and presentation. And we receive resources for projects such as help from the CDI2 data team at the Office of the President, project planning, support, and shared documentation. On this slide, I summarized the various pharmacy collaborative teams across UCI or UC Health system. We have many collaborative teams, as I said, and these work on pharmaceutical solutions to population or specialty-based issues. For example, if there's a shortage with a medication for infectious disease, it will impact all of our pharmacies. Both the infectious disease and purchasing collaboratives may be involved to develop plans to address this type of shortage. We partner to develop system-wide solutions for both efficiency as well as shared learning and mentoring of colleagues. Despite our best efforts, there are challenges to collaboration. Oftentimes, pharmacy regulations create logistical barriers. Organizations may have varied levels of resources, including time, personnel, and information that influence how shortages are managed. Sometimes just maintaining an accurate count of drug inventory can be a challenge if a hospital does not have an electronic inventory management system and maintains what we call a manual count. There's also a competitive nature that may impact behaviors when it comes to shortages. Hoarding of drugs or decreased transparency with regard to inventory status may result. There's also medical ethical considerations, which may drive how limited drug inventory is deployed. I'd like to pivot at this point and share a real-life example of a recent drug shortage. This occurred in 2023 with an oncology drug called, actually there were several oncology drugs, but cis and carboplatin were specifically affected. There was a nationwide shortage, as I mentioned, and this, at that time, over about 90% of hospitals were actually involved and experienced some sort of drug shortage impact with oncology agents. And even today, in 2024, many oncology-related drugs remain in very short supply. This particular drug, or drug shortage with cisplatin occurred because a major pharmaceutical manufacturer, Intas Pharmaceuticals, had significant violations of good manufacturing practice. There were challenges to meet regulatory demands, which caused a shutdown in manufacturing and led to the nationwide shortage. Ultimately, the US government got involved and permitted the importation of cisplatin from China. In the meantime, the Society of Gynecologic Oncology issued alternative drug therapy guidelines to address the shortage. And organizations such as Angels for Change were created to assist patients with finding drug sources to treat their condition. Once the cisplatin shortage was recognized at UCI Health, the team highlighted this item in our weekly drug shortage meetings. We created a chatbot to give early notifications of inventory status from the FDA and National Pharmacy Society called ASHP. The graphic that you can see on your screen is the actual tool that the UCI team was using and continues to use to track drug shortages. The yellow highlighted column, week supply on hand, has a red, yellow, or green stoplight symbol to basically indicate to us how rigorous our conservation strategies need to be. The pharmacy team communicated our situation with stakeholders and staff, and we did reach a critical low with this particular drug. Cisplatin was triaged to the appropriate locations, as we have multiple infusion centers where our patients receive care. Our buyers made purchases from multiple vendors while leveraging our wholesaler purchasing options. We closely monitored the patient schedule and commingled our patients to minimize waste. Our pharmacists worked closely with our physicians to identify the most critical patients, and we also procured the cisplatin that was imported from China and used this product for our patients. Because the drug package insert was in Chinese characters, it required us to provide additional education to our pharmacy technicians regarding how to compound the medication. Based on this and a growing need to have consistent communications with our oncology providers, an oncology subcommittee to the Pharmacy and Therapeutics Committee was created. As the situation improved, we continued to communicate with affected parties, clinicians, and pharmacy staff until our inventory was back to desirable levels. I will now welcome my colleague, Dr. Kathy Yang. Thank you.
Thank you, Dr. Zhou. As Dr. McRae mentioned, I am Dr. Catherine Yang from UCSF School of Pharmacy. For the remainder of this time, I will try to highlight the unique challenges that we see associated with antibiotic shortages. So you can see from this graph, while in the United States, we focus on national shortages, we have to remember that antimicrobial shortages are really a global health crisis with particular impact on low and middle income countries. You can see from this slide that the list includes some very common antibiotics, such as amoxicillin and cefazolin, but these also include some very specialized antibiotics for multi-drug resistant infections, such as ceftolozane tazobactam, as well as antifungals, such as amphotericin B, and tuberculosis medications. Unlike high-income countries, many of these low and middle-income countries do not have the resources to deal with these shortages or to substitute one drug for another. In 2022, the US experienced a national shortage of amoxicillin suspension. This really was the perfect storm. This started in late 2022 as the COVID-19 pandemic was starting to wind down and the United States was starting to emerge out of social distancing and isolation. During this time, we saw the rise of what has been termed the triple-demic, a rise in 3 different viral upper respiratory infections, which include respiratory syncytial virus, COVID-19, and influenza. This led to then an increase in prescribing of amoxicillin, particularly amoxicillin suspension among pediatricians. At the same time, we also did see an increase in shortages in liquid ibuprofen and acetaminophen. To add to the perfect storm, there was a sharp rise in invasive group A strep infection. And this is just a graph that was sent out by the Centers for Disease Control to just highlight this event. And you can see that in late 2022, there was a rise in invasive group A strep infection at the same time that we see increases in both influenza and RSV. What's also noticeable about this graph is you can see that during the pandemic between March 2020 and June 2021, there really wasn't too much of any of the three. And that was, of course, because of social distancing and isolation during the pandemic. The sharp rise in group A strep infection led the CDC to release this Health Advisory Network Alert, or HAN, in late 2022. The collateral damage due to antimicrobial drug shortages has been well documented in the literature, so I thought I would highlight the key concepts for you here today. The first are delays in therapy, and this is really due to multiple factors, including the need to track down inventory by pharmacies and physicians, as well as develop contingency plans. But we also have to remember that these delays in treatment are very impactful, particularly upon our most vulnerable populations. We did hear in the media of patients who had to drive back and forth between multiple pharmacies in order to get their prescription fulfilled. This, of course, is very, very difficult for our most vulnerable populations that don't have the resources to do so. And in many cases, many patients opted to not get treatment at all. We also saw an increase in medication errors, and this is due to the use of either alternative dosage forms or requirements for drug substitutions. For instance, substituting one concentration of amoxicillin suspension for another, or in some cases needing to use alternative dosage forms such as chewable tablets or capsules. These all, of course, led to multiple medication errors. We also saw increases in adverse events due to drug substitutions. These can be simple side effects, such as nausea, vomiting, or diarrhea, or in some cases led to more severe adverse events, such as cardiac arrhythmias, or even increased infections due to Clostridium difficile, or C. diff, due to use of more broad-spectrum antibiotics. When the more preferred antibiotic is not available, we often then have to move on to second-line therapies. This then leads to a decreased effectiveness for the treatment of these infections, especially when the shortage is for an antibiotic that is active against a very specific or rare infection, such as multi-drug resistant gram-negative infections, mold infections, and across the world, we saw this happening with tuberculosis. And probably the most significant collateral damage due to antibiotic shortages is the rise in increased antimicrobial resistance when we have to substitute more broader spectrum agents for the more preferred agents. And last but not least, there is an increased cost. This cost occurs for both the patient, who has to pay more out-of-pocket medications for for more tier 2 medications or not preferred medications, as well as costs to the healthcare system. It's estimated that each antibiotic shortage leads to about $30 million in direct costs. And when you factor in labor expenses, this leads to an additional $360 million annually. This interrupted time series just illustrates two of the broader spectrum agents that were used during the amoxicillin shortage in 2022 and 2023 for acute otitis media or ear infections. So on the left, you have amoxicillin clavulanic acid, and which is Augmentin. And on the right, you have ceftonir, which is a third generation cephalosporin. And you can see that the usage did go up during the shortage. The good news is these prescribing patterns did come down with some time as the drug became more available. The bad news is that we can see there were some long-lasting effects on prescribing patterns as these rates of antibiotic prescribing of the broader spectrum agents never did quite return down to normal. or baseline. Yeah. So then we had another perfect storm in April of 2023, and that was the benzathine penicillin shortage. In late 2022, the CDC sent out this report called Vital Signs, Missed Opportunities for Preventing Congenital Syphilis. And what it showed was between 2012 and 2022, there was a 10-fold increase in newborn syphilis cases during this 10-year period. In 2022, the CDC found that almost 9 in 10 cases of newborn syphilis might have been prevented with timely testing and treatment during pregnancy. And more than half were among people who tested positive for syphilis during pregnancy, but did not adequately receive treatment in time. So why did this occur? So interestingly, benzathine penicillin is only manufactured by one company in the United States. And they really cited 2 different reasons for this increased shortage of benzathine penicillin. One, as we saw before, was the increase in congenital syphilis cases, which were already on the rise. The second was actually due to the ongoing amoxicillin shortage, which increased demand of benzathine penicillin among pediatric physicians. This was actually not a bad choice because it is a quite narrow spectrum agent, but this augmented and worsened the shortage. And as of the current day, the pediatric formulation of benzathine penicillin is still unavailable. This slide and ribbon graph just highlights the health disparities associated with congenital syphilis. So as you can see from this graph, Black and African American people, while they only represent about 14.3% of live births in the United States, they actually account for almost 30% of our congenital syphilis cases. This is also true for Hispanic and Latino patients, as well as American Indian and Alaskan Natives. You can see that they have disproportionately higher cases of congenital syphilis compared to live births. And these last 2 slides just show a survey from the STD clinics, and it was done by the National Coalition of STD Directors. And they found that in the past 3 months, health departments from 13 different states reported that they had multiple pregnant people who were unable to access benzathine penicillin. Most respondents were able to confirm that pregnant people could not immediately get penicillin, and 56% say they could not get treatment within 1 week, and 31% said that it took anywhere between 8 days and 28 days to receive treatment, which just highlights the significant delays in therapy for these vulnerable populations. The second slide shows the impact on clinic operations and workflows. So clinics have had to navigate the shortage without additional resources, and you can see there was increased difficulty in ordering stock, and there was delays in either receiving stock or not receiving stock at all. So 46% of clinics attempted to order benzathine penicillin, but it was not available. 55% of clinics had their orders completely unfilled or had more than half of their orders unfilled. And 40% of clinics have had their penicillin orders delayed in the past 3 months. What isn't shown is the significant time and resources spent trying to find stock and implementing contingency plans, such as reserving stock for pregnant people and finding alternative treatment options that are affordable and accessible for everyone. This, of course, then impacts the care of non-pregnant people, and use of second-line agents, such as doxycycline, then requires additional spent time on follow-up care. So what is the solution? Unfortunately, outside of rationing drug, there wasn't really a lot of great options. One solution that the US FDA did was to allow for the import of foreign benzathine penicillin. And in November 2023, the FDA issued a Dear Healthcare letter that laboratories Delbert from France would be allowed to import drug to the United States. While this was a good idea in theory, this also led to additional confusion similar to the oncology drugs that were mentioned earlier due to differences in labeling, warnings, and dosage forms. The US version of benzathine penicillin is actually a pre-filled syringe, but the French version required reconstitution. It also included different warnings on the potential hypersensitivity due to the excipients or the inactive ingredients in the product. And from a cost perspective, this drug, extensiline, was quite expensive and not initially covered by either US insurance companies or 340B pricing. Most recently, Mark Cuban's Cost Plus drug company received FDA approval to import and distribute benzathine penicillin from Portugal at a reduced cost of only $15 per dose. So how do we manage antibiotic shortages at the institutional level? So regardless of whether we're doing this within our individual institutions or with our communities, we have to really do so with a focus on health equity. And at the institutional level, this requires extensive coordination between the pharmacy department, our institutional antimicrobial stewardship programs or ASP programs, and when necessary, bringing in expertise from our ethics and our health equity committees. This is just to ensure that we are developing protocols that are equitable and increase access to our most vulnerable populations. Also, we need to make sure that we have outreach and communication that is key, that is transparent and timely, and includes all of our stakeholders. And this is just to build trust within our providers and our patients. And finally, a lens on health equity outside the institution. So when we manage antibiotic shortages, we can't just do this in a bubble. We have to include all of our partners from outside the institution. These include our local and state health departments and our public health departments, our community partners, including our community advocates and our health educators. This also includes our other local health systems and hospitals that are within our network and within our city and county that may not be UC hospitals, but that's okay. And as mentioned earlier, this also includes expertise from our UC Pharmacy Collaborative, as well as sharing resources within our other UC system hospitals. This is really to develop shared protocols and contingency plans for everyone, not just patients within our system. And we did this quite well during COVID-19 in San Francisco. We were able to create shared protocol and contingency plans, and most importantly, we did not hoard resources at the institutional level. Whoever had the most patients received the most drug, and if anyone ran out, we immediately couried over product from one institutional to another. The do not loan or do not share policy just didn't apply at that point. And it didn't really matter whose patients we were treating. It went to whoever needed it the most. And with that, thank you for your interest in these topics. I will now turn it over to Dr. McRae.
Thank you very much, Dr. Yang, and thank you to all of you for the exceptional presentations. So we've been collecting some questions as they appear on the Q&A feature. You can use it still as we proceed for the rest of the session. But one of the first questions is regarding the ADHD medications. Many of us are aware of the prolonged shortage of ADHD medications such as Adderall or Vyvanse, whether we're seeing it on the media or hearing it through the media or having experienced this firsthand as clinicians, patients, or caretakers of patients. I was wondering if one of you could kindly comment on this issue.
I can take that question. So the shortage of ADHD medications is a little bit differently. different from the others in that it is related to the fact that there's manufacturer quotas imposed by the Drug Enforcement Agency, the DEA, as these are controlled substances. This has been discussed for quite a few years now, and there's a little bit of controversy because the DEA seems to say that manufacturers are not fully using their quotas, but manufacturers argue that the lack of ability to meet demand is really driven by these quotas. And I think there's been some discussions in Congress and some letters sent from congressmen to the DEA to think about lifting or at least raising the quotas. But I like to think that that's a little bit differently from the shortages that we have discussed today, as it has a component of regulation that is quite atypical.
Thank you very much for that information. Maybe we can talk more about the federal oversight. Is there a central agency which will define and determine exactly when we have an official shortage? And if so, what exactly can they do? What power do they have to intervene and address the problem? And is there any way to expedite this?
I think the only authority that exists right now is related to when drugs go on the FDA shortage list. And bear in mind that drugs get there from manufacturer reports. So this is not about the FDA monitoring drug supply, but rather adding drugs on the list when manufacturers report those. So sometimes we've shown in research that some drugs may get added to the list, although necessarily the supply hasn't decreased. But for instance, the fact of whether those drugs are on the FDA list is what triggers whether additional flexibilities can be used to bring more drugs to the market. I'm sure you may have heard recently about compounding pharmacies and Ozempic and other type of semaglutide products. That was allowed because semaglutide was on the list on the drug shortages list. So that allows compounding pharmacies to produce the drug. The policy levers that FDA have to work around shortages are limited. They tend to expedite, for instance, applications of additional manufacturers, or as my doctor, Dr. Yang, explained, they try to increase flexibility around importation, but it is limited what the federal government can do in terms of coming up with additional manufacturers that can compensate for a manufacturer going on shortage.
Thank you very much. So we have all heard in the news about Baxter manufacturing being affected by a hurricane and impacting our supply chain. So Dr. Joe, could you kindly comment on that?
Absolutely. I think that's been a hot topic lately. So many of us are aware that Hurricane Helene, due to really the torrential rains, right, that occurred in North Carolina, flooded the Baxter North Cove facility, which was a primary facility for production of IV fluids. Many institutions, and the UC system included, used Baxter for IV fluid supply, as a primary vendor. And so realistically, a number of different things. I mean, I think kind of just as I described in my presentation, I think everybody probably immediately took stock of what inventory is on hand, what has been the general use, and then from there started to deploy various mitigation strategies or conservation strategies to really conserve the supply that we have. The way this particular shortage is kind of playing out is that each facility is receiving an allocation, which is a percentage of the total quantity that you historically purchased. Because it's only a partial supply, right, of what your normal use is, even though we are continuing to get these supplies in, I think, we need to be very conservative here. We need to continue to conserve our use by the kind of various measures that you can see on the slide that we have here. I know many facilities have converted to smaller size IV bags. So there's minimizing waste. I think there are certain procedures where it was just kind of commonplace to hang an IV fluid, and folks are really thoughtfully considering whether or not they should start one. I can say at UC Irvine Health, we've converted a lot of our antimicrobial antibiotic infusions to IV push. These are all those conservation strategies, I think, that we have in place to minimize the use. While at the same time, I think all of our procurement specialists went out and sought perhaps new agreements or trying to truthfully find new suppliers, right, to offset the the small amounts of fluids that are coming in. So this is an ongoing situation, and honestly, I mean, I am hearing that Baxter won't be fully up until maybe mid-January of 2025. So this is going to go on for some time.
Thank you very much for that insight and all that information. Next question is regarding the economics of what we're talking about. Specifically, why can't prices rise to incentivize producers?
So I really appreciate that question because that's something that probably I should have included on the slides. And that's something that I get asked all the time, right? So it's like, if you're saying the prices are too low, why can't they raise them? It's not as easy. So first thing, when drugs are used in the inpatient setting or the outpatient setting, hospitals are paid based on how much the drug costs 2 quarters ago, meaning 6 months ago. So for instance, the drugs that we are providing these days in October 2028, the reimbursement from the insurance company or Medicare to the health system is based on the price of the drug in April. The problem with that is that when manufacturers raise prices, health systems don't want to buy their drugs because they go underwater in terms of reimbursement. So that is one of the reasons why the way how we are paying for drugs incentivizes manufacturers to raise prices. Another is what we call inflation rebates. And this is a little bit of a small policy point, but basically, for instance, in Medicaid, there's a law that says that if manufacturers raise prices above inflation, the price increase above inflation needs to be refunded back to Medicaid. And the same thing applies on the 340B program. So there's cases when manufacturers may raise prices, but they are actually not making any more money. This is particularly the case, and this is a big issue because some of those inflation rebates are referenced to 2017. So there were cases where drugs had already taken strong price decreases and were at prices near marginal cost. And now basically any increases in prices because manufacturers have to pay for additional costs or like increased cost of production, they basically need to be refunded because of this law. So in some of those cases, manufacturers say, you know what, I'd rather shut down the production of this drug and instead use it to produce, I don't know, compounded Ozempic because it's much more profitable than producing IV ciprofloxacin, for instance. The final reason why it's not so easy to raise prices is because in the contracts that group purchasing organizations have with manufacturers, basically any price increase trumps the contract. It will no longer be binding. So although it seems like it would be the easy solution, it's not as simple because of the way how the drug supply and the reimbursement chain works. I hope that was not too much of a complex answer.
Thank you. That was a great answer. Okay, the next question is about hoarding of medications, which we've heard a great deal about in the media. So would someone be able to comment about whether or not hospitals should be hoarding medications?
Yeah, I can answer that. So I think we have to really approach the idea of shortages from a more public health perspective than an institutional perspective. In the past, I think there was more of a reliance to sort of keep our drug for our own patients. I think over time we've learned that that isn't the best approach because it isn't the most equitable approach. We should be sharing our resources as much as is possible within our neighborhood hospitals and our partner organizations. What gets difficult, I think, is when each of these different institutions have different protocols for drug use. And there was a question in the chat about how does the UC Collaborative handle RSV shortages? For one, it is helpful to align as much as we can our treatment guidelines within individual hospitals to make sure we are being as equitable among our centers as possible. That is one approach to doing that. But the idea of holding on stock at one institution to use for that institution's patients in the future when another hospital could be using it is not exactly the most equitable approach. So it's highly been discouraged.
Thank you very much, Dr. Yang. All right, we are coming to the end of our session. And if you have any other questions, I am sure that our speakers would be more than happy to assist. And I really appreciate everyone's time. The speakers spent a lot of time working on this presentation, and the information was incredibly helpful to a wide variety of professions as we try to provide the best care to our communities. As a reminder to participants, tomorrow you will receive an automated email with instructions to provide feedback and claim continuing education units for participation. Thank you again, everyone, for joining, and have a wonderful day.